We're good now? So welcome everybody to our first session of live surgery here at Swedish Issaquah. We're doing a Tympanoplasty today. Can they see my screen? Yeah, so if you could look on my screen here, I'm using a 0-degree endoscope and going through the ear canal here, and we can see that this patient has really almost a subtotal perforation here with just a little remnant of the malleus handle you can see here. Can't really see the ossicles just yet, but we'll see that in a second. So yeah, we're going to do a Tympanoplasty, meaning we're going to reconstruct this eardrum. Can we show the audiogram? So this patient has a pretty severe mixed hearing loss that we're going to try to improve by fixing this hole for him. So here we're going to put some cottonoids soaked with 1/1000 undiluted epi. Always do this for at least a few minutes to help achieve any further topical vasoconstriction on top of the local that I inject before we started videoing. Keep it one more, yeah. Thank you. Usually about 4 or 5 is enough. Okay. So we're going to go get some tragal cartilage now for our graft to fix this hole, or what we call perforation. All right, let's see here. You guys see what I'm doing when I'm going to get this cartilage graft, or no? No? Okay. Maybe. I don't know. It's up to you. Why don't we do this? I'll just get the graft, and then I'll show you how I carve it and mold it. That's more important. Can I have some local, please? Okay, injected about 1. Another 15 blade, please. Double prong skin hook. Thanks. Add some with teeth and an iris scissor. So as you'll see, my plan is to use the tragal cartilage and perichondrium as 2 layers to really reconstruct this perforation. So after I harvest this graft, we'll carve it into some grafts, which I'll show you in a minute or so here. Yeah, 15 blade. Brown Adson, please. Our scissor, yeah. And what I really try to do when I harvest this graft is I don't take the tragal tip, which enables the ear to maintain the same contour. So there's no obvious cosmetic deformity or sign that I've taken cartilage out. Do we have the bovie, please? Great. I like to gently cauterize some of the soft tissue anterior to the cartilage that I harvest. Really gentle with the needle tip bovie just to prevent any sort of post-operative hemorrhage, which is pretty rare, but when it does happen, it can be quite painful for the patient. There you go. Okay, you can come out. Have a 5-0 fast, please. Great. So we have two sides to this cartilage. Both sides have some tissue on it. Typically, the anterior side of the tracheal cartilage has a lot of redundant muscle and fascia from the parotid. And so I use an iris scissor here flatly on the graft just to trim off any excess muscle, really get down to pure perichondrium to the extent possible. There you go. Nice white. And then the other side, the posterior side, generally is pretty thin already. But even then, I'll trim off some if there's some to be trimmed. Okay, I'll take a round knife, please. Now I'm going to peel off the perichondrium on both sides. You know, in training and going to other courses, I've seen people leave the perichondrium on one side and do what's called a composite graft, the tracheal cartilage and perichondrium. I prefer really just to peel it off both sides. And I'll explain why as I do the grafting. But essentially, I think with the contour of the eardrum, sometimes it's a lot easier to place the cartilage and perichondrium separately versus trying to really get the whole unit to oppose the perforation. So I just peel out the posterior side. Now I'm going to peel up this anterior side, which we said is a little thicker tissue here. I use a round knife because, you know, it really enables you to get in the right plane here to start. Otherwise, the tissue just shears. And there you go. You can see we're starting there. And there you go. So we peeled off the perichondrium on both sides here. I use this back of this iris. You know, you can use a press. I found that a little messy with perichondrium. I have to use the back of the scissor like this just to kind of stretch it out. And here we essentially have two soft tissue grafts. Come a brown Adson. Here you go. Got it. Okay. So there you go. There's our soft tissue grafts that we can use. And then do you have an 8 speculum, please? And a marking pen? Is your video okay? So I'm using a speculum now because, you know, the tympanic membrane is about the diameter of 8 millimeters. So I use an 8 millimeter speculum, ideally to create a nice circle if I can. This is not working so well for me today, but there you go. That's essentially the circle there. I'm going to cut around this circle. There you go. And then if you imagine, half of the circle is going to be for the anterior part of the tympanic membrane, and half is going to be from the posterior. I basically cut it in half. There you go. We have 2 grafts there. Okay. All right. Let's move this light away. You got the grafts. Oh, 5 suction, please. Thanks. So one thing I always do, which I didn't do because I was distracted by the recording and talking to you all, was I usually trim these hairs. Can I have a small scissor? So trimming hairs is actually really helpful for endoscopic surgery. These hairs tend to collect a lot of moisture and blood during the case. And if you're taking your endoscope in and out, you'll notice as the case goes on, it just gets foggier and foggier because of the hairs. So try to trim them to the extent where there's nothing kind of hanging in your way, and you can advance the endoscope and the ear canal without significant fogging and blurring. And I like to use a big scissor for this. I just think it's easier. You can use a Bellucci scissor too if there's a lot of very fine hairs medially in the canal, but I like to use an iris. I think this is actually safer. Bellucci's can be pretty sharp and really cut the skin and create some unnecessary bleeding. There you go. Okay, can I have an alligator? There you go. And I'll take a 3 suction, please. So I'm gonna take a rosy needle now. So what I'm gonna do is I'm gonna first rim this perforation. This patient already has some frayed edges here, but the idea is to basically create a fresh surface on the tympanic membrane to heal over the graft. So here we go. Just gonna, sometimes I'll actually take off a big rim. Other times I'll just do this. I'll just kind of score it, just kind of rough it up essentially. I found that either works. Sometimes you can even use a crab tree if there's really not much rim left at all. I'll use a crab tree and go under it and just kind of rough the undersurface of the drum. That seems to work well too. Can I have a cup forceps, please? The main point is you don't want any strands kind of migrating and falling inwards, and then you put a graft in, and then you trap skin in the middle here. So yeah, I'm just gonna gently pull this off. There you go. Have a 3 suction. So here you can see a pretty good portion of the middle ear. And soon we're gonna proceed. You okay? Now we're gonna proceed with elevating the tympanic membrane here. Can I have a number 2 suction round knife, please? So I like to use this Grace Medical number 2 suction round knife. As we stated, I have no disclosures, but I do like to use this because I think it does help generate a nice long flap that's pretty anatomically intact. So I make a pretty wide and long incision here in the ear canal. Generally feel that the longer the incision, the longer the flap, the better with these cases. If it's too long, sometimes you can't, the flap can get in your way, but I don't find that happens very often unless the canal is really quite narrow, in which case your view is already quite limited. So already we're getting down to the annulus. You can start to see this area here. But especially with a subtotal perforation like this, the wider the flap, the easier it's going to be for you to do your work. I use this round knife really until I feel like I'm getting down close to the annulus, and then I switch. Can I have a cottonoid now? I have a 3 suction. So there you go. If we look under our cottonoid, we can kind of see the annulus we're starting to see it here where the drum is kind of getting stuck here. Can I have a round knife now? There we go. We see the yellow annulus here. We see chorda tympani nerve right here. Yep, you can see our ossicular chain and our incus and our stapes in a second here. Can I have an annulus elevator now, please? I call this an annulus elevator. I know a lot of people call it a gimmick. Right, train in Dallas, they called it an annulus elevator, so that's what I do. Here we go, lifting the annulus here. Lifting the tympanic membrane. I'm gonna take the cotinoid out. Alligator, please. There you go. Annulus, please. You see our malleus here. We can see actually our anterior edge. Now, sometimes these canals can be quite narrow inferiorly and anteriorly. You can't see this, but it's still doable endoscopically, thankfully. There you go. So we're seeing our malleus. Can I have a 3 suction now, please? Got our chorda tympani here going underneath the malleus. Our ossicular chain is kind of covered by the scutum here, but you can see this is the incus and the stapes right here. Have a Rosen, please. Eustachian tube orifice, cochlea, hypotympanic air cells. All right, Rosen. So we can see when we move the malleus, we're getting movement of the incus stapes. A little bit hypomobile, but I am seeing movement, so that's okay. All right, I'll take some gel foam. And when I say gel foam, we're actually using Stryker Otopore, which I like because it's a little bit more fibrous, a little bit more rigid. I think it tends to work pretty nicely with holding the grafts in place, or helping to support them, I should say. And my goal here is to just put enough packing where it's kind of abutting just under the anterior edge of the perforation here, because that's really where the graft needs support so it doesn't fall in. And I try to do a monolayer. I don't want to put too much in because it makes it kind of messy for the graft placement. Oh, a little blurring. And then posteriorly, I do put some, this guy, I can't see the ossicular chain as well, but I want to generally get the packing up to the lateral level of the incus if I can. I think it helps the cartilage sit better. Maybe one more piece. Okay, so now we're going to put our cartilage grafts in. Can I have the white block? Does anybody have any questions so far? Nobody? Okay. Hopefully that's a good thing. Alligator? So you saw how I cut the cartilage graft in half. What I'm going to do is I'm going to do one piece of the half moon anterior to the malleus, and then, and then one piece posterior to the malleus. Rosen?
We have a question.
Yeah, please.
Does the Stryker packing last the same amount of time as gel foam?
The question, does it last the same amount of time?
Yeah.
I think it lasts about the same amount of time. I think it's about 4 to 6 weeks. We'll talk about that in a second. I think of this stuff more as 2 purposes. One is mechanically supporting the graft. The other purpose is creating inflammation, kind of like Scotch tape, kind of helping things stick together. But my sense is it lasts about 4 to 6 weeks. I'm going to put the second graft in, the posterior graft. So we saw the anterior graft is abutting the remnant there, but we'll put in our cartilage grafts now. Maybe downsize this a little bit. There you go. Rosen. And there you go. So we can see our malleus is right here. We can see one graft is posterior to it, the other one is anterior to it, essentially reconstructing the whole tympanic membrane. You know, if you ever worry about the saccular chain, you can always lift up this graft and try to look. I'm not going to do that right now, but you can see everything is nicely laying in place here. This is a little proud, so I may just trim this graft a little bit here. Can I have an alligator, please? Small scissor. Rosen. So I just trimmed the cartilage graft a little bit. I felt like it was maybe a little big, and you know, I want to see it kind of lay in here kind of pretty freely if I can. Sometimes easier said than done, but there you go. There you go. So now we're going to put our graft in, alligator, and we're going to put a piece of perichondrium. You can use either side here. You know, I don't think it really matters with these anterior, posterior. I try to use the one that feels like it's the right size. And there are two ways you can do this. You know, one way is you could just put it medial to the malleus, which is what I tend to do in most cases. Another way is you can actually go and, Rosen, you can actually peel off the drum off the malleus and do what's called the medial lateral tympanoplasty, meaning you do the graft lateral to the malleus handle, but medial to the tympanic membrane remnant. Both are, I think, are okay. You know, I will say that, let me put this in and then I'll give you my opinion on that suction. I will say that I think the hearing outcomes, you know, in the sense of hearing improvement takes a little bit longer when you do medial lateral, but it's definitely, of course, an acceptable technique, and many people have written about it. So here we can see our anterior graft kind of up near the remnant. We can see our perichondrium. My goal right now is to kind of sneak it underneath the, can you plug my suction for a second? Just kink it, yeah. Rosen is to place it underneath the malleus. So sometimes this is easier said than done. In this case, this malleus is a little medial. You know, we could see it right there. So I'm going to try to sneak it under there. And then often, you know, with the anterior perforations, I'll actually lay the flap down like this. And I'll actually work over the flap. I'm a little blurry, sorry. Any other questions?
No other question.
No? Okay. 3 suction. Actually, I have a 20 now. Thank you. Frozen. There you go. So you can see I did that final move there to really get it to tuck underneath the malleus handle there, which is right here, which is a little medially rotated. Do you have a cup forcep? And then here, working over the flap, I'm just going to fine tune the pericondyal graft. Rosen. So we can see the nice tympanic membrane remnant here. We can see it's a little propped up, but that's okay. You can see the pericondyal graft is nicely approximating it. And this looks pretty good.
We have a follow-up question about the striker packing. The striker packing creates a little inflammatory reaction, which, quote, helps things stick together. Can you expand on that?
Yes, the idea with gel foam, which is collagen packing, which is different material than striker. Can I have a 20 suction? So when I used to use gel foam, and I still do sometimes, depending on which site we operate at, the idea with gel foam is you're putting it in and use it as structural support, but it definitely creates some sort of inflammatory reaction too. So the idea is that you'll see, I'm going to put some gel foam over the graft here, Rosen, but I think of the gel foam not so much as like packing the ear canal tight to keep the grafts in place. I think of it as more as placing it over the exposed graft and all the edges of skin to get everything to stick together. So my sense is using Otopore, it's probably a similar thing that happens. I think there's also some general inflammation that generally happens as the ear canal skin and the drum heals. So that's what I mean. So my point is I don't use the packing kind of as pure structural support and just go crazy packing the ear canal. I use it judiciously. I hope that makes sense. But here I'm just being anal retentive because that's how I am. But you can see the graft is nicely under the drum here. Everything looks good. And there's not a lot of movement. I can take a 20 suction here. This is often the last check. I'll just gently take a 20 suction with my finger off the hole. Suction around and everything looks really good here. Now I'll take some Otopore. Yep, keep coming. Yep. Give some antibiotic ointment. Now I'm going to put some mupirocin ointment, which I always do. Just keep things nice and clean. And then I generally have the patient start ofloxacin antibiotic drops about 2 weeks from now. And then we usually see them at 3 weeks, in which time everything's pretty clean. There's pretty minimal clean debridement and packing needs to be removed. And then we get a hearing test about 2 or 3 months after surgery. And usually hopefully they're pretty happy. Usually they are. There you go. Now, can I see that white block again? So we have some cartilage left over. I like to put that back into where I'll be done in about 5-10 minutes. I like to put some cartilage back into where I harvested it. Just in case, you always want to plan for the worst in case this doesn't work and you have to come back. And I don't really like harvesting conchal cartilage very much, so I often just bank this cartilage. Have a brown Atson, please. There you go. Can I have a stitch again? Scissor. Okay, any other questions? Finish a little faster than I think we expected, but that's okay. Anybody? No? Okay. Thanks for attending. On June 27th, I will perform an endoscopic tympanoplasty with ossicular chamber construction live via Zoom. Look forward to seeing you there.